Assalamu alaikum. We will start our next session now. This is on bone marrow transplant. The chair of the session is Dr. Yasmi. He's a consultant hematologist and director of bone marrow transplant service in Shifa Hospital. Dr. Yas, please come on the stage. And he'll be accompanied by the co-chair, Dr. Syed Waqas Imam Bukhari. He's a transplant lead and consultant hematologist in Shaukat Khanum Hospital, Lahore. We have 4 talks. One is virtual, one is live, and two are virtual. One is virtual, sorry, and one is live. First of all, I'll invite Dr. Syed Usman Ahmed. He's a consultant hematologist in adult bone marrow transplant services in King Faisal Specialist Hospital and Research Center, Riyadh, Saudi Arabia. He's a CAR-T lead there, and he's going to be giving a talk on the CAR-T.
Okay, thank you very much to the organizers of this symposium, and thank you very much, Dr. Bushra, for the introduction. I hope you can hear me and see me. Right. So the talk I was asked to give was about the short and long-term challenges and what we have learned so far in terms of CAR T-cell therapy. So now so I'm going to try to break this down a little bit in terms of where we are and what we have learned so far, and some of the challenges, especially the medical short and long-term challenges, but then some of the more pressing challenges in terms of delivery and access. So the CAR-T journey so far has been quite an amazing journey. This is a theory that started in 1989 in terms of trying to get T cells to do what B cells are, what antibodies would normally do, and that is, the theory was, can you attach an antibody to a T cell and activate the T cell so this T cell can kill cancer cell? And this started in the late 1980s and went through the early 2000s, and it was only about 10 to 15 years ago that the first cases were being treated in clinical trials. And a lot of that happened in the University of Pennsylvania. And I'm sort of going to quickly go through the journey. And then 2017, we had the first FDA approval, first for ALL, then for NHL, and now we have a number of products. So here is where we are now. I've incorporated some of the approvals that happened in the Kingdom of Saudi Arabia as well. So we do know that it's a complex process of manufacturing, and it is logistically burdensome. So now the problems and that's one of the problems that arises, namely that we are having to send cells, collect cells from patients, process them, and send cells to either North America or Europe. It takes 3 weeks for these cells to be manufactured, and then for them to be brought back. Now, and that is a challenge. Now, here's a quick overview of the CAR T-cell process. So just a reminder for the viewers. So what is involved is that T cells are transduced with a vector, and this vector then transfects the cells. That leads to a chimeric antigen receptor being expressed on the surface of the cell that's targeted to, in this case, CD19, and that leads to release of certain mediators that lead to cell death. Now, how do CAR T cells kill the tumor cells? It happens by a number of processes. Including granzyme and perforin, then CAR T cell derived cytokines that lead to interferon upregulation. And in this antigen milieu, you get cells targeted by the Fas ligand, and that leads to cell death. Now, we do have a number of approved therapies at the moment for BALL, NHL, and multiple myeloma. So for BALL, we have Tisacel. For younger patients, we have Brexacel or Tecartus for older patients over the age of 18. For NHL, we have Yescarta or Axicel for diffuse large B-cell lymphoma, follicular lymphoma. We have Kymriah for also diffuse large B-cell lymphoma and follicular lymphoma in the second and third line, or rather in the third line for Tisacel. The BMS product, which is called Breyanzi, Lysocell, also for diffuse large B-cell lymphoma, both in the second and third line. And we have Tecartus and mantle cell lymphoma. And we have 2 CAR T cell therapies for myeloma. So if we think that the first registration happened in 2017, we've come quite a way in the last 6 years. And you just have to look at this graph to see the uptake of CAR T cell therapy over the last few years. And this is data from the CIBMTR. And this is up to 2021. And a number of approvals, especially second-line approvals, have happened only in the last year. So you can imagine how this curve will be rising in the years to come. And this is a breakdown only up to 2021 for CAR T cell cases reported to CIBMTR by indication. So this field is rapidly growing. I'm going to quickly try to run through some of the studies that came out for lymphoma. So these are the registration trials for CAR T cell lymphoma and NHL. You have Axicel up here. That was for the third line from 2017, followed for 5 years later by the Zuma-7 trial that led to the approval for Axicel in the second line. You had the initial trial for Tisagen in the second line therapy, or third line therapy rather, Tecartus for mantle cell lymphoma, and Lysocell in non-Hodgkin lymphoma. These were the responses in the third line setting. And these are the overall survival Kaplan-Meier curves for each of those agents: Axicel, Tisacel, and Lysocell. Now, this was work by Mehdi Hamadani, coming from the CIBMTR data, looking to see whether you do need CAR T cells in the PR setting. And I'm going to come back to this. And I think this is going to be an important slide, an important study for a lot of the emerging economies, a lot of the developing countries, as to what do we do for patients who have partial remission. These patients need a CAR T cell therapy, or is it okay for them to still have the standard autologous transplant? And this seems to suggest that there is still space for an autologous transplant for patients who have a partial remission after salvage therapy in non-Hodgkin's lymphoma. So how about the second-line therapy, autologous transplantation versus CAR T cell therapy? And we had 3 pivotal trials. Zuma-7 confirmed the efficacy of CAR T cell therapy in patients who have a first relapse, and they were randomized to an autologous transplant or CAR T cell therapy. And this study and the follow-up study confirmed the place of Axicel. The endpoint in that study was EFS, but a more recent update has shown a benefit in overall survival as well. So now this has become the recommendation both by the EBMT and the CIBMTR and also in the NCCN guidelines. So if somebody's had early relapse within 12 months, the standard of care has now become CAR T cell therapy. Similar study was published for Lysocell, the BMS product, or Breyanzi, which showed an EFS advantage and an overall survival advantage for second-line CAR T cell therapy. So that's a summary of where we are in non-Hodgkin lymphoma in the second-line setting for patients who have especially early relapse. So Axicel passed, Lysocell passed, but unfortunately the Kymriah or the Novartis product failed that second-line study. So Axicel and Lysocell are approved in that indication. So that was non-Hodgkin lymphoma. How about ALL? We have two products, Tis-cel for younger patients under the age of 25 and Brexucel for patients over the age of 18. So you have this overlap, age of 18 to 25, when you could theoretically use either. So, and these are the constructs for those two CAR T therapies. So the Novartis product here on the right and the Kite product on the left. So this was the initial study, the phase 2 Ileana study for Tis-cel, and really it was a real paradigm change, because we remember how these children fared and how these young adults fared when they relapsed either after a transplant or after chemotherapy. They really had a dismal outcome. And then this really revolutionized how we are able to approach relapse refractory ALL with a 12-month survival of 76%. This is real-world data that confirmed those outcomes. How about in older patients over the age of 18? We now have Tecartus, which is a slight modification of Yescarta, and this was the Kite product. And again, the patients went for a similar treatment, leukapheresis, bridging therapy, and they had conditioning therapy, and then they were infused with Brexucel. And CR was 56%, overall responses were 71%, and those are the outcomes stratified by their responses. Now, in our own institution, we have been using Kymriah since 2020, the end of 2020. And on the left, these are combined PFS and overall survival in single curves. So the progression-free survival, as you can see, for ALL in patients getting Kymriah was very impressive compared to what we used to get. And the PFS for diffuse large B-cell lymphoma was a lot poorer. This is the overall survival. If you just look at overall survival on the right, in patients who received Kymriah. So the top curve is almost 100% survival we were getting for patients being treated with ALL for Kymriah, and that was the overall survival, for patients treated with diffuse large B-cell lymphoma. And we have now two products for multiple myeloma. Cilta-cel, the curve of which I'm showing, I won't be showing the ide-cel, because really Cilta-cel seems to be the winner at the moment. So that's very impressive for patients who've had almost 4 lines of therapy. So the progress so far, so CAR T-cell therapies have become an established line of therapy in NHL, B, ALL, and myeloma, and the usage is increasing across, higher income countries. And trials and real-world data for early use and other indications are emerging. So patients are being treated for, say, Burkitt lymphoma, plasmablastic lymphoma in small cohorts, perhaps off-label. And now you have all these trials for novel constructs. So what are the challenges in terms of medical challenges? Now, I show this picture of Northwick Park Hospital in London, where some of you may remember about over 10 years ago, there was a trial using an immunotherapy in young, fit patients with this antibody construct. And it made the news because these patients were having severe toxicities. Some of these patients I was then looking after in Northwick Park Hospital, because the hematologists look after them after they have problems. So, and that was very scary, and it led to lawsuits and various problems. And so when CAR T-cell therapy started, and that first child, Emily Whitehead, had severe toxicities, people got really, really scared. The patient went to ICU, and they had really bad fevers and hypotension. And these were their profiles of their cytokines. And it just so happened that Carl June, one of the primary investigators, his daughter had rheumatoid arthritis and was being treated with an anti-IL-6 agent. And they saw the IL-6 peak, and they treated them with an anti-IL-6 agent, tocilizumab, with marked improvement in symptoms. So this was a toxicity profile in that initial trial. As you can see, 77% cytokine release syndrome, 40% neurological toxicities. So these are some of the main toxicities of CAR T-cell therapy: cytokine release, ICANS, which I'll talk about later, infections, febrile neutropenia, and organ-specific toxicities. And because of those toxicities, specifically cytokine release syndrome that occurred with the initial trial, When the FDA approved CAR T-cell therapy, they also approved the anti-IL-6 agent to treat the cytokine release syndrome. There were similar toxicities seen in the Tecartus study with ALL, and as you can see, actually, it's probably the most toxic agent that we use, 25% grade 3 or greater neurotoxicity, despite the excellent response rates. So this is the CRS grading. It's graded based on very simple parameters: fever, blood pressure, and the need for oxygen. And they're treated with tocilizumab and steroids. The other toxicity is the immune effector cell-associated neurotoxicity that we've learned more about over the years. And as I mentioned, it could be quite severe with the CD28 kite products. That's what it stands for. And these are some of the clinical manifestations of it. So speech problems, cognitive impairment, motor weakness, cerebral edema, and altered level of consciousness. And they can also get certain subtle signs like dysphasia or aphasia, writing problems, and a tremor. In our own institution, we've looked at the frequency of these toxicities, and we found that we've seen maybe slightly less toxicity than is in published data. So over here on the left, we see CRS. That is all grade, and that's grade 3 and 4. That's Juliet, real-world data, but that was our data here on the left. So we actually saw less severe CRS. And this was ICANS in NHL over here, king facial data, and we saw less toxicity than in the published data here as well. So, but in all cases, we try to make sure that people in our department are well educated, physicians, nurses, residents, and we've put it on the door as to how to grade it and how to treat it, so that people don't have to look up in the middle of the night, try to find some IPP as to what to do. Here we delineate how, when you give IS tocilizumab, when you give steroids. But there's a whole range of other toxicities that we've learned about over the last few years as more and more data emerges, and CAR T-cell therapies can really affect any organ. One of the other emerging toxicity is what's called ICAT, or immune effector cell-associated hemotoxicity. And some can argue that this is probably one of the most frequent toxicities. Cytopenia is an infection. It could be early and late, and it could be treated with GCSF and TPO agonists to try to boost the hematopoiesis, but sometimes these patients need transplants. So the current challenges with CAR T-cell therapy in terms of failure are mainly this: antigen escape, some of the on-target off-tumor effects, problems with CAR T-cell trafficking and infiltration, especially that's why the solid tumor trials aren't advancing, the immunosuppressive microenvironment, and some of the CAR T-cell associated toxicities. So that's about the clinical challenges. Now, how about, more importantly, in our economy is delivery and access? And the elephant in the room, as they say, is cost. The financial toxicity. How do we get over the financial toxicity of CAR T-cell therapy? How do we stop healthcare systems becoming bankrupt as we use these in earlier lines and as we have more therapies available? So we need to think of cost, affordability, access, and once we've dealt with that and we actually have access to CAR T-cell therapies, we need to be able to train staff and develop the resources for supportive care. Now, there are approaches in the West to mitigate cost, agreements with companies to try to have reimbursement based on outcomes, and these are some of the approaches that have been used in the big 5 EU countries. So even over there, they have agreements with the vendor to say, we will only pay you the full price if the patient has a certain outcome, if a certain population have a certain outcome. But even with that, these drugs are very expensive. And how do we square that against challenges in the Marrow region, where the Eastern Mediterranean region that includes Pakistan and the Middle East will have the highest rates of cancer in the years to come, and a significant rise in cancer mortality and morbidity. And this was a study that came out supported by the Economist, actually. So if you look at these curves or these circles, Egypt, look at the rise in cancer over there, both in terms of cancer and cancer deaths. in all of the Middle Eastern countries and Emma region, we will see increase in cancer morbidity and mortality. So then how do we deal with that with these really expensive anti-cancer CAR T cells? How about point-of-care manufacturing? This was an editorial that came out of Mayo saying that, the current CAR T cell therapies are unaffordable. Can we make them at a cheaper cost in-house? Clinic Barcelona in Spain did that. They provided CAR T cell therapies on what's called a hospital exemption to a limited number of centers for patients who didn't have access to commercial therapy. So that covered about 10% of patients who needed CAR T cell therapy. And the hospital exemption is a provision whereby patients can get a CAR T cell produced in-house under certain strict guidelines. Now, I provide these slides from one of our scientists, Dr. Farhatullah, that yes, this is the machine that is used as Clinimax Prodigy machine for cheaper CAR Ts. And it is made simple, but it's not as simple as it may be made out. Yes, it's a lot cheaper, but it's not. It's probably about 20% to 30% to 40% cheaper, depending on the cost of reagents to make that. Because there are lots of other devices and equipment that's needed to make a CAR T cell in-house. So in terms of cell and gene therapy, there are challenges everywhere. There are universal challenges if you want to manufacture at a lower cost CAR T cell therapy, either in your institution or in your country. So there's some universal challenges that include talent, a bottleneck for production for a lot of the reagents. We in the Kingdom of Saudi Arabia have challenges in terms of regulation, availability of some of the reagents that are needed. And we have institutional challenges, including supply chain, getting these reagents, getting these kits, tubing and equipment, even within our institution, takes time, needs talent, and needs funding. So in terms of this, people talk about we want to produce in-house because we can't afford to buy. Then you just need to have a thought about what it is that you want to produce. Do you want to produce a product that you take from invention to registration? That does take time, and it does take a village, like what UPenn did. You may want to collaborate, and you may want to try to get a vector from a third source, from a third party, get the vector and try to transduce cells internally. That's doable. Or you want to be a manufacturing hub. And that's quite ambitious if you want to have a large ecosystem. Now, for example, India did this. They wants to make CAR T cells at a cost of 50,000, and they have just published some abstracts in ASH about how Immunil and the Tata Memorial have actually registered a CAR T cell therapy, which they hope to provide at a low cost, and they did that in collaboration with the Barcelona clinic. Abu Dhabi recently were able to get a vector from Germany, and they were able to produce and treat a patient with in-house CAR T cells. So if you want to develop a strategy in an emerging economy, because we know that CAR T cells are unaffordable, then we need to explore alternative technologies. But you do need to develop talent. We do need scientists and young scientists going in the field of genetic engineering, vector production, cell and gene therapies. You need to work to develop in-house production capabilities, and it's important to collaborate. And I show this slide because this is all the pipeline of various therapies and various targets. But I want to show this to say that we all know that actually China is one of the leading countries in this field in terms of clinical trial. And we are collaborating with the Chinese in, say, gene therapy. And that is something that our colleagues in Pakistan should really explore to develop in-house capabilities. And say, for example, solid tumor CAR T cell trials, 74% of those were happening not in the USA, but in China. Then we need to think of how we develop ecosystems, institutions, small startups, scientists, small companies, collaboration with the outside. And that will be needed if you want to develop your capabilities to develop cell and gene therapy. I'm just in the closing few slides, I'm going to highlight, one outfit, for example, Caring Cross. A lot of these people on the right were people who were involved with developing the initial CAR T cell and the vector construct in the initial registration trials for Kymriah, borrow droplet, etc. And they have set up this organization, for example, Caring Cross, where they want to collaborate with the developing countries to develop low-cost CAR T-cell therapies. This isn't an endorsement, but it's just for information. Then one thing to think about is there's a lot of talk about CAR T-cell therapy, CAR T therapy, CAR T therapy, but let's not forget that there are still alternatives. For example, you can still do an auto transplant in a patient who has a PR for NHL, even in the NCCN. They don't necessarily need CAR T-cell therapy. Transplantation is still there. It's not dead. We need to still make that more accessible. We still need to do cheaper interventions to try to prevent relapse. BiTEs and monoclonals are competitive for CAR T-cell therapy. If they're accessible, they're a lot cheaper, and you don't have that whole logistical chain of sending cells and waiting, etc. And then we need to have realistic expectations, whether it's here or in Spain or in the UK or in Pakistan, there will be patients who will not be able to access CAR T-cell therapy for whatever reason, whether it's being unable to pay or whether it's regulatory restrictions. So patients need to be selected very carefully for whatever therapy you want to give them. Anyway, this is where we are with autologous therapies and CAR T-cells. The future is very exciting. There's going to be a manufacturing evolution. CAR T-cell therapies will have to become cheaper as the field evolves, and we will see CAR T-cell therapies in solid tumors. And there's a whole range of targets that will be targeted. There are lots of priorities across CAR T-cell process, which I think our colleague, Dr. Mohammed, will talk about later. And with that, I'd like to end. Sorry for going over time, and I'd like to thank you for your attention.
Thank you very much.
We'll introduce our next speaker, Colonel Raheel. Everybody knows him already. He's one of our best assets and has done a lot of work in research publication and supporting the cause of transplant across Pakistan. Sir.
Thank you very much. I'm extremely grateful to all the organizers for inviting me in this wonderful conference. So I'll be talking about newer approaches to make bone marrow transplantation safer and stronger. There are no conflicts of interest or disclosures. If you look at transplant evolution over decades, in initial 3 decades, there was only minimal transplant activity. And most of that was attributed to the fact that most of the transplant attempts initially in first 2 decades were actually failed attempts. But there was an exponential rise in transplant activity after 1990, and there were 2 factors which actually contributed to this exponential rise. One of them was actually introduction of calcineurin inhibitors to prevent graft versus host disease, and other was improvement in HLA typing, which resulted in reduction of graft failure. So as a result, after 1990, there was an exponential rise. And along with this exponential rise in transplant activity, there was also improvement in survival. So if we look at outcomes from CABMTR data of myeloid malignancy, there was a gradual increase from around 35 to 40% to around 60 years probability of disease-free survival at 3 years. And this was attributed to the fact that as the transplant field moved forward, there was better identification of different risk factors which affect transplant outcome. And if you look at this column, there are 2 factors, that is relapse and non-relapse mortality, that actually decides the outcome of transplant. And it is actually a fine balance between these 2 factors, which is actually modulated by different further factors which are highlighted by Nicholas Kruger in Hematologica, and these are disease-specific, patient-specific, and transplant-specific risk factors. So as we'll move forward with the talk, we'll discuss all of them. So if we want to improve our transplant outcomes, there are different transplant goals which needs to be achieved. These include improving supportive care, reducing transplant-related mortality, prevention of relapse, minimization of graft versus host disease, and above all, accessibility to transplant. This accessibility does not only mean financial accessibility, but it is accessibility to a broader audience who are then eligible to undergo this procedure. And if you look at this accessibility, one of a major contributor was evidence-based expansion of transplant indications. So now different societies have actually pinpointed different indications backed by evidence, which actually help us to decide which patients to transplant and whom not to transplant. Another major breakthrough in increasing accessibility was the ability of transplant physicians to do transplant across HLA barriers, and haploidentical transplant is a classical example of that. And then making transplant safer and feasible for elderly population. So if you look at this EBMT categorization of indication of transplant, they have very aptly actually categorized into standard of care, clinical option, developmental, and those who are not recommended. So these recommendations are evidence-based, and they actually guide the transplant physician to choosing whom to transplant, whom not to transplant, with ultimate aim of reducing non-relapse mortality and balancing out the risk of relapse. So if we look at example of acute lymphoblastic leukemia, and if we see that a patient is Philadelphia positive, CR1, MRD positive, it would be a standard of care indication to transplant this patient with a match-related MUD or haploidentical transplant. But if a same patient is MRD negative, then the risk of transplant-related mortality would be approaching that of relapse-free survival, and the haploidentical transplant is given an indication of clinical option. The further decision definitely would be a number of, depending upon patient-related factor, centers experience, how they are comfortable with doing that procedure. So these indications have actually helped the transplant physicians in decision of whom to transplant and whom not to transplant. Another major factor which increased the accessibility was haploidentical transplant. And if we see this green curve, there was a rapid rise in transplant activity after 2012-2013 in haploidentical field. And this actually correlated with the advent of post-transplant cyclophosphamide by Johns Hopkins group. So Johns Hopkins post-transplant cyclophosphamide platform actually provided a cheaper option to undergo haploidentical transplant with outcomes which are sometimes as good as match-related donor transplant. So once the haploidentical field moved forward, there were further recommendations in choosing best haplodonor, which further helped to improve outcomes. And this is an article by Stephen Curry et al. And we see that now for T-cell replete haploidentical transplant, the recommendations are more or less clear, like MFI levels of less than 1,000, a younger donor, male donor, sibling donor, and between parental donor, father is preferred over mother donor, and a lot of other variables to choose the best donor. So choosing a best donor, having a good conditioning platform with GVHD reduction in the form of post-transplant cyclophosphamide has actually improved the results dramatically. So if you look at this study by Rashidi et al., this is actually a CABMTR registry data of outcomes of haploidentical versus match sibling transplantations for AML in first CR. If we look at these two curves, so outcomes are actually comparable. And the most interesting thing is that if you look at this bottom table for graft versus host disease, chronic GVHD, it was significantly inferior in haploidentical transplant, which was attributed to the use of post-transplant cyclophosphamide. So having a haplodonor, comparable outcomes, and a significantly reduced chronic graft versus host disease. Now, if you look at the CABMTR data and the percentage of different age groups who were transplanted in 2021. So if we focus only on this bar, 29% of the patients who were transplanted in 2021 were more than 65 years of age. So around 1/3 of the patients were transplanted who were more than 65, and this blue curve actually increased gradually over last 2 decades, starting from 4% to 29%, and it is bound to increase. And this actually added a lot of large pool of patients who were previously not being considered eligible for transplant. And these elderly patients were the physicians were managed to transplant them with better outcomes because of better assessment tools and better conditioning regimens. So now there are better disease assessment tools, especially focused on elderly and geriatric population, which help to choose our patients who are to be transplanted. And then individualizing conditioning regimens within that cohort of elderly people. So within even RIC conditioning regimens, different conditioning regimens can be individualized depending upon the patient risk factors, their comorbids. For example, considering Flumel 100, Flumel 150, Bu alone in different doses, or Flu-Bu regimens, depending upon risk of relapse and non-relapse mortality. So within the RIC regimen, there are different individualized conditioning, which has helped the transplant physicians to transplant these elderly population. If you look at CABMTR data of all-cause mortality, around 1/3 of the deaths are due to treatment-related mortality. Around 33% of the deaths are due to treatment-related mortality. So if we reduce treatment-related mortality, the outcomes are bound to improve. So how to do that and how the transplant community is coping with that? Now, there are better risk stratification and comorbidity prediction tools. This is a simplified form of comorbidity index, which actually substitutes conventional HCTCI index. It was developed by Memorial Sloan Kettering, a simplified tool, which is a validated tool to predict mortality in our population. If you look at new EBMT and ASTCT guidelines, now there are clear indications of which patients to be transplanted in CR1 and which to be transplanted in CR2. It is because of the registry data backed by evidence that if you delay transplant in transplant eligible patients, the outcomes are bound to be inferior. So they are superior in CR1, then CR2, and afterwards, or those who are not in CR, the patient's outcomes gradually become poorer. This is more so evident and more so relevant in our population, in which we know that our patients are financially constrained. There are only limited treatment options that are available. And as we say that the first shot is the best shot. So if you take example of acute myeloid leukemia, there are now standard recommendations that if you have got a HLA match donor, then you do a transplant in intermediate risk, and for adverse risk, you do a transplant either with haploidentical or with match related or MUD, because if you delay transplant, these patients, especially in our setup, have a lesser probability of going into remission. They are more likely to decompensate and add to it financial toxicity. So earlier the transplant, earlier the better, especially in those indications in which it is evidence-based. And we know that more is not always better. And the act of transplant is actually a balancing act. It is a balance between relapse and non-relapse mortality, as we discussed previously. So this was on behalf of Acute Leukemia Working Party of EBMT, a study which was published in 2020, and it actually modified the conventional concept of conditioning toxicity into MAC, RIC, or non-myeloablative, and it actually renamed into high, intermediate, and low toxicity, gave them a validated scoring system, and then graded the conditioning toxicity accordingly. So with the purpose to individualize the conditioning regimen, to reduce toxicity, and then to assess retrospectively on the basis of data available that what is the best conditioning regimen for our different disease. And if you look at example of acute myeloid leukemia, so conventionally we know that BuSci was supposed to be a standard of care protocol, but this randomized trial by Rambaldi et al. Actually compared BuSci with BuFlu in patients who were eligible for transplant between 40 to 65 years of age, and it showed that use of fludarabine with busulfan was associated with lesser non-relapse mortality, but there was no increased risk of relapse with the use of BuFlu in this population, the so-called now reduced toxicity myeloablative conditioning regimen. We know that CMV is a major cause of morbidity and mortality post-transplant. Availability of letermovir, which actually reduced CMV reactivation rates from 41 to 17%, and later maribavir for refractory CMV patients with a CMV negativity rate of 57%, and most importantly, there were no marrow suppression or nephrotoxicity. So we always actually struggle with our CMV reactivation, especially in benign disorders. We put them on anti-CMV medications and the marrow actually just crashes. So use of maribavir is a breakthrough medication, not available with us, but we hope that we will get it. Minimizing graft versus host disease is another aim. If you look at this study, chronic acute graft versus host disease grade 3 and 4 is associated with significantly inferior survival as compared to patients who do not have GVHD or have grade 1 or 2 GVHD. So acute graft versus host disease directly impacts morbidity. This study by Nicholas Kruger was one of the seminal articles that was published in New England Journal of Medicine, and it actually incorporated the role of ATG as GVHD prophylaxis against chronic GVHD. And we can see that the outcomes in hematological malignancies using PBSC as a graft source were clearly favoring use of ATG. And this actually led to EBMT to give their recommendations for use of ATG in malignant disorder. And if we see that myeloablative conditioning, PBSC, irrespective of donor type, is now a recommended indication for use of ATG in hematological malignancies. As we have seen a randomized trial of MUD versus haploidentical transplant and significantly reduced chronic graft versus host disease by use of post-transplant cyclophosphamide, now PTCY is increasingly incorporated for match-related donors as well. And if you see this forest plot, overall survival, PFS, GRFS, non-relapse mortality, and moderate to severe chronic graft versus host disease all favor post-transplant cyclophosphamide and match-related donor population as well. Now, from prophylaxis of GVHD, we'll move to management of graft versus host disease. And we know that ruxolitinib with REACH-2 trial and REACH-3 trial in chronic graft versus host disease was a major breakthrough, which actually had a significantly superior GVHD-free, relapse-free survival in target population, which led to its FDA approval. And the newest addition is belmosadil, which is a rockstar inhibitor, and it got its FDA approval in 2021. It is only for chronic graft versus host disease and those who had failed 2 lines of treatment. And lastly, the relapse prevention is another goal, which is an important goal, as we see that the major cause of mortality and morbidity post-transplant is either due to non-relapse mortality and relapse, which is responsible for around 2/3 of deaths post-transplantation. Different strategies have been developed over the last 2 decades for relapse prevention post-transplant. It starts from optimizing conditioning regimen, achieving MRD negativity, induction of graft versus leukemia effect, use of targeted agents, and novel strategies. One of the questions that was always being asked in malignant disorder is the use of RIC versus MAC. So BMT-CTN trial was a randomized trial that actually answered this question, and it clearly showed that the use of RIC was associated with more incidence of relapse, but lesser transplant-related mortality. If you look at overall survival and relapse-free survival, it favored myeloablative conditioning. So the recommendation conclusion was that if a patient is eligible to receive myeloablative conditioning, MAC regimen is superior to RIC regimen. For ALL, this meta-analysis and systematic review actually validated the role of TBI as a conditioning regimen, clearly showing that all the variables in different meta-analysis, different randomized controlled trials and observational studies supported the use of TBI as a primary conditioning regimen in acute lymphoblastic leukemia. Now, this was an important study. It was published by Richard Dillon this year, and it actually showed the role of melphalan-based conditioning to reduce relapse in match-related donor patients who are MRD positive at the time of transplant. So there are two groups. One is RIC regimen patients for myeloid malignancies who were transplanted without melphalan conditioning, and one with melphalan conditioning. And within that, those who were MRD negative and those who were MRD positive. So in patients who are being transplanted with a RIC regimen using melphalan-based conditioning and they are MRD positive, incorporation of melphalan actually reduces the risk of relapse and resulted in significantly superior overall survival. And we know that relapse prevention, now one of the major goal is to get the patient into MRD negativity. It has been validated in ALL that MRD positive patient at the time of transplant should be taken to transplant, and one should try to get them into an MRD negative status, preferably with the use of BiTEs. Blinatumomab is one of the agent that is approved both for Philadelphia negative and Philadelphia positive patients who are MRD positive. So it is always preferred to transplant these patients in MRD negative status. In addition to that, there are innovative strategies for prevention of relapse. This involves use of post-transplant blinatumomab maintenance, use of inotuzumab, ozogomycin, and even CAR T cell therapy in combination with allogenic stem cell transplant for relapse prevention post-allo. Maintenance therapy post-transplantation has always been pondered upon. There was evidence from use of tyrosine kinase inhibitors in Philadelphia positive ALL that introduction of targeted agents improve survival. Sorman trial was a trial that actually proved, it was a randomized trial, the efficacy and utility of sorafenib as a maintenance therapy in FLT3 AML patients post-transplant, and use of sorafenib was associated with better progression-free survival and overall survival in FLT3 patients. It is a cheaper drug and is available. And once we move to maintenance in autologous stem cell transplant, we know in Hodgkin lymphoma, ATHERA trial is one of the trial that actually documented the progression-free survival of Hodgkin lymphoma patient using brentuximab vedotin. With more and more BV-exposed patients, now there is data to support the use of BV plus checkpoint inhibitors. Mantle cell lymphoma and follicular lymphoma, we know that LIMA and PRIMA trial documented the utility of rituximab. And for multiple myeloma, randomized trials IFM 2005 and KELGB actually documented the efficacy of lenalidomide maintenance. And now International Working Group of Myeloma has recommended use of PI plus lenalidomide in high-risk myeloma patients. So I conclude by saying that the field of transplantation has evolved significantly over the last 5 to 6 decades, and it has developed from a field that was considered dead in 1960 to an exponential growth, and it is bound to grow despite all the other modalities of treatment that are coming up. Thank you very much.
Thank you, Dr. Rahil, for a comprehensive talk. So I would now like to invite our next speaker. So Dr. Munira Musaji, she is a consultant hemato-oncologist at Aga Khan University Hospital, Karachi. She is the director of the BMT program and an associate professor in medicine. She's going to talk about chronic graft versus host disease, what's new on the horizon.
All of our friends, and thank you for the Shaukat Khanum team for the gracious invite. So Rahil set the stage up really nicely for me, because as the field of transplant is growing, we have to be very cognizant that we need to make our transplant safer. So the patients come to us, one thing is cure the disease, but they do not want to live with the consequences of the treatment. And so I'm going to take a deeper dive into chronic graft-versus-host disease. And just going back a little bit to the pathophysiology and kind of understanding where the priming takes place. The priming for chronic graft-versus-host disease really takes place very early in the transplant course of the patient. So patients who have acute graft-versus-host disease, they're already primed for chronic GVHD. All of the T cell, the alloreactive T cells, which are primed, are just ready to go, ready to kill. And they start affecting different organs, particularly the thymus, the bone marrow, leading to a very dysregulated immune system. Now, jump forward a couple of months when the donor immune system is starting to come up. And that is when the entire storm starts to kick in. And that leads to eventually this growth of cytokines, especially the ones which are the pro-inflammatory cytokines, the interleukins, the interferon gamma, activating the macrophages, the fibroblasts, and then leading to the bane of our existence, which is the fibrosis, which happens throughout the body. So we love scoring systems, as you heard in our previous talk as well. And so there is another scoring system for chronic GVHD. And what this does, it really puts things into perspective. So a patient who is diagnosed with chronic GVHD, this is a very old paper, about 12 years old, published in Blood. And it's really super simple. What it does is it gives a score of 0, 1, 2, and it puts it, and the patients are charted according to what is the cumulative incidence of non-relapse mortality. And nothing hurts more for a transplanter than a patient dying, not because of the disease, but because of complications. So the higher the cumulative incidence, the score, the higher the cumulative incidence of non-relapse mortality. The next question is that what really causes a non-relapse mortality? And it's a plethora of things. And in this, chronic GVHD itself is contributing to about 40%. Then you have infections because of the treatment of chronic GVHD, organ failure because of chronic GVHD, for example, lung toxicity, so on and so forth. And because I don't have the time to go into details with the infections, but this is a serious concern in these patients because they are on immunosuppressive therapy for the long haul. So when you're looking at organ involvement and when you're seeing your patient come into clinic, this is just by the frequency of the organs that are going to be involved. And these are a combination of 3 large data sets, the IBMTR1 and 2 and an NMDP. And the most common organ set is cutaneous. We all know that, very, very frequently seen. And the mucous membrane, so the oral cavity, and the eyes are extremely important. The gritty eyes that the patient really complain of. Unfortunately, we don't have that much of expertise in eye GVH from our ophthalmology colleagues, and we've been trying to grow that at AKU. So this is something to look at and to be cognizant about. And what I actually try and do in my clinics, that I have a checklist of every post-allo patient who comes in, and we have to check it off to do an entire examination. If anybody wants those, I'm more than happy to email me and I'll send them to you. So the mechanistic interventions for prevention of chronic GVHD. So it's so a way to look at this is that all of the different systems and pathways that interplay when you are trying to manage chronic GVHD. So Raheel touched very quickly upon the post-transplant cyclophosphamide, and this really comes in the prophylactic phase, where you are playing with the stem cell engineering and the alloreactive T cells. But then there are certain drugs and targets which are actually they kind of transcend through the alloreactive T cells into the regulatory cells and the autoreactive T cells, such as, and we'll talk a little bit about, a lot more about in detail with the ruxolitinib, the ROCK inhibition. And I don't really want to forget ibrutinib here, even though it's gone a little bit out of favor with the recent papers that came out this year. But this is a drug that we do still have available. And so we really need to not take our guns away and try and sequence them properly. So the treatment of chronic GVHD, like acute GVHD, has remained corticosteroids in the first line, and nothing has really supplanted it. I mean, people have tried, and I will show that in the next slide, but corticosteroids are the first line of treatment. You can give this with a calcineurin inhibitor or not, and that is what most of us do with cyclosporin or tacrolimus. But we all know what happens when you give corticosteroids for a long time. And the thing with GVHD, which is something not as commonly seen with acute GVHD, with chronic GVHD, these patients are on steroids for a long time. Your indication to jump and calling somebody steroid refractory or steroid resistance is a lot longer than what you would stay in acute GVHD. And so we need to be aware of what's going to happen to our patients who take corticosteroids for a very long time. And as I said before, there are lots of studies that were done that were using prednisone, either with azathioprine, cyclosporin, thalidomide, but all of these, unfortunately, did not show any benefit or were terminated early because of toxicity. So therefore, steroids were and have been the mainstay. And there was a lot of hype with the Integrate trial. There was very, very good signal in the phase 2 study. This went on into the phase 3, ibrutinib plus prednisone versus placebo plus prednisone. And the whole idea was that chronic GVHD at 48 weeks, does ibrutinib improve responses? And again, the secondary endpoints, and I want you to try and remember these because these actually will come into conversation a little while later. And so unfortunately, this was a negative trial and really kind of deflated a lot of the transplanters with a very, very insignificant p-value, overlapping curves for both the primary and a very key secondary endpoint. But as I told you before, just remember the secondary endpoints, but it did show an improvement with a decent hazard ratio of failure-free survival. And more importantly, I think when you're looking at the patient's end, duration of response. So with a significant p-value and a nice separation of curves there. So just switching gears very quickly to secondary treatment. And so we have our definitions: steroid refractory and steroid dependent. Steroid refractory is those patients who progress or we are unable to taper the prednisone down. And steroid dependent is those with chronic GVHD who when they will flare as soon as they get to a very low dose of prednisone. So they're very dependent on the prednisone. And you can assume that these patients are going to be problematic in the long run. And that is where before ruxolitinib came in, there was a plethora of studies. Everything was tried. Rituximab was tried, imatinib was tried, pentastat and mycophenolate mofetil. But the problem is all of these were either retrospective studies or they were phase 2 studies. So you really couldn't hang your hat on any of them. But individual studies showed very decent response rates, but these drugs do have a role in certain clinical situations. So let's not throw them away just yet. And then the REACH3 came out, and this was the home run. This was ruxolitinib versus best supportive therapy, and these were all the ones that were being used. And overall, and the primary endpoint was overall response rate at 24 weeks, which was a very significant p-value, a home run for the investigators, and an NEJM publication in 2001. And majority of them had either moderate or severe graft-versus-host disease, which was 50% of them. The secondary endpoints, failure-free survival and duration of response, excellent for the ruxolitinib group. So ruxolitinib now becomes the second line in steroid refractory, approved second line in steroid refractory disease. But what do you do when they are ruxolitinib refractory. So now we have a new definition of ruxolitinib refractory. And this is where ROC comes in. So ROC is row-associated coiled protein kinase, and I did need to learn that. So it is 2 isoforms. An easy way to remember this, that it interplays between the fibroblasts, and the inflammation causes increased extracellular matrix and makes life hell for the organ. And so it's belmucidil is the name of the drug. The KD025 was the alphabet soup when it was in the preclinical studies. Rockstar study, I think, was at ASH last year, if I'm not mistaken, or 2 years ago. And so this was, and so this led to belmucidil was approved on a phase 2 study because it was at such an orphan indication. And so this was an open label phase 2 study, 2 dosages of belmucidil, overall response rate as a primary endpoint, and a whole host of secondary endpoints right there. And this is the kind of forest plot everybody likes to see, like all the bars really nice and tight, all showing improvement with belmucidil, irrespective of the severity of GVHD, irrespective of the organs, whether they had prior ibrutinib or ruxolitinib use. And now belmucidil is now considered the go-to drug after ruxolitinib refractory GVHD. And when you're looking at where does this respond, it responds pretty much everywhere in the body, with the best response seen in the joints and the fascia and the GI tract. So now where do we put our older drugs into the armamentarium? So I just went back and I looked at some of the older data, and so we have ruxolitinib thankfully available, and it's going to be available for our patients at the time we have the access program. We don't have belmucidil available. So what do we do tomorrow when we go back to our clinics? So that's why I wanted to talk a little bit about ibrutinib. And this was in the chronic graft versus host disease setting in the steroid refractory patients, not up front. And in this population, this was a phase 1, phase 2 study. So please take that with a grain of salt here. So there is no randomization, but it did show a very decent overall response rate of 69%. And these responses, what is heartening to see, that these responses are sustained at 20, 32, and 44 weeks. And interestingly, about 64% of these patients were able to decrease their corticosteroid dosages. So what you're doing is you're really piling it in and trying to balance the side effect of one drug versus the other drug. The other chronic graft versus host disease therapies that I'll quickly touch upon, extracorporeal photopheresis. I think Rahil's institution is the only one in the country that has that. But I mean, and he will probably be able to tell you it's extremely hard to do because the drug is difficult to get and expensive. But extracorporeal photopheresis has been there for decades, and it has shown to have a decent response rate, a good control of disease. But I feel like where I trained, we used to do this quite often, and the most amount of responses we saw was in cutaneous GVHD, and I think that's where it still has a role. Rituximab is also something that we can use. It really didn't have the response rates were not very good, but what it did show was a very statistically significant reduction in steroid dependency and a reduction in the steroid dose. So that is something to consider for our patients in the long run. They tried to compare rituximab and imatinib, and this was again a negative study. So one drug over the other, I mean, you can pick your poison. So what do we do from this point onwards, right? So, and as physicians, how do we kind of reconcile with the soup of information that we have? So one is clinical efficacy. We always want to do right by our patients. So you want to look at the clinical efficacy, looking at the data that's out there. Some drug coming in with a phase 3 trial is something that you can bank on. Kind of like doing your own QC and looking at, what is the data? Is a retrospective study or a prospective study? Looking at toxicity profile and individualizing your toxicity profile for your patient, because no one shoe doesn't really fit all. Very important. Now I want to kind of concentrate a little bit on the patient aspect of it. Hum jo karte hain, wo karte hain, but that poor patient has to live with it for the rest of his life. So we really need to make their lives a lot easier. So mode of delivery, a patient will always prefer an oral therapy over any IV therapy that requires a lot of intervention. Patient compliance, you want to have that kind of relationship with your patient so that they don't fall into the cracks. And we keep on talking again and again about cost and availability. So I think like talking to in forums, being part of international groups, reaching out to your friends and colleagues to bring in clinical trials to our country. We have a whole bunch of patients, we have the network. And so I think this is something we really need to, as a group, kind of focus on. And I think we earlier talked about, I think when Anida was talking about her CML story, we were talking about guidelines which are nation-based rather than international-based. And I think 3 years ago, we started the Pakistan Bone Marrow Transplant Society, and hopefully within the next maybe a month or 2 months, we should be publishing our chronic GVHD and acute GVHD guidelines, which are going to be specific, looking at the cost of the drugs and the availability of the drugs in our country today. So it becomes something that we all can really rely on. So take home points, and I have 3 minutes. Chronic GVHD, it remains the most important long-term complication, and I can't stress that enough. And it's the bane of existence for all patients and physicians. I think what I did not really comment on is really meticulous assessment. So you can't really be blasé about seeing your chronic GVHD patients. Meticulous assessments and very clear grading of GVHD for early recognition and preemptive therapy. So you're not going to wait for your patient to develop horrible systemic sclerosis or fibrosis and then try and reverse the situation. You want to try and get to them earlier rather than later. So understanding the biological pathways has really led to new therapies and has really, improved our armamentarium for GVHD as a whole. Ruxolitinib, as we talked about, is the favored second-line therapy. Belmucidil is right behind it. And, and even though we have other drugs that might not have that same home run, but they do have a place to pay. And I think we should not, and ibrutinib would be something that we all should consider. And I'm going to stop right there, right in time. Thank you so much. And we'll take questions at the end.
So it's time for a last talk. It is setting up CAR T cell therapy service. It is by Dr. Mohammed Saif. He's a consultant hematologist and bone marrow and CAR T lead in Leeds Hospital, UK.
Thank you very much for inviting me to do this talk on setting up CAR T cell therapy service. My name is Mohammed Saif, and I'm Director of Bone Marrow Transplant and Cellular Therapy Program in Clatchbridge Cancer Center in Liverpool. So I will largely share my experience of setting up a CAR T cell therapy service in 3 different centers from different backgrounds. So in my talk in the next few minutes, I will do a brief introduction to CAR T therapy. Then we'll talk about why do we need it, particularly in Pakistan, what is needed in order to set up CAR T program, how to get there, and then I will have some conclusions and suggestions. So we all know that CAR T cell therapy is a type of immunotherapy And a subclass of immunotherapy that this treatment belongs to is called adoptive cell therapy. We have two different basic types of adoptive cell therapy. One is immune sensitized cellular therapy. It does not require change in genetic composition of the immune cells. And the other one is genetically modified cellular therapy. And the examples of this kind of therapy are CAR T cell therapy and CAR NK cell therapy and so on. So what is a CAR T cell? It is a T cell which is taken from human immune system, and then by a process called viral transfection or electroporation, we insert a gene of interest into these T cells. This gene inserts itself into the host genome, and after insertion, it goes through the process of transcription and translation, which results in formation of a hybrid synthetic protein called chimeric antigen receptor, which sits on the surface of these T cells and turns them into CAR T cells. This figure shows a cartoon of how a chimeric antigen receptor looks like. As you can see in first generation CARs, we have an extracellular antigen recognizing domain, which is connected to transmembrane domain via a hinge. Then we have intracellular domain, which is essentially a T cell activating domain. In second generation CARs, we have a co-stimulatory domain, which helps in proliferation. And in third generation of armored CARs, we have multiple co-stimulatory domains. And these can include genes, which result in formation of other cytokines and chemokines, and also proteins, which can be used as a switch-off mechanism in uncontrolled CAR T cell proliferation. So how do we provide or give CAR T cell therapy? So we, by a process called apheresis, take the T cells from the recipient. Then we send it away for CAR T manufacture for genetic changes of the T cells. And then we get the final product back. We lymphodeplete the patient, prepare them, and infuse these T cell products into the recipient and see the magic happen. In United Kingdom, with an NHS commissioned service, initially two products were commissioned. One was called Escarta, which is a product of Kite Pharma, and the other one is Kymriah. Now we also have Tecartus, which is also a CD19 CAR, which is used for lymphomas, mantle cell lymphomas, and also acute lymphoblastic leukemias. And in imminent future, we're expecting myeloma CARs to become available free of charge for all patients who are eligible with multiple myeloma. So why do we need this type of treatment, which is very expensive? It's a new innovative treatment. And these are data from 124 patients that we submitted in the initial NHS England commissioned service. And as you can see, those patients who are not treated with CAR T had a median survival of roughly 2 months. So it's for some patients last resort of last line of treatment. It's a cutting edge technology, and it forms the basis and provides you technical capability and understanding of giving other treatments such as hematopoietic progenitor cell-based gene therapy. It provides lots of opportunities for research, collaboration, builds a national and international profile, and I can only imagine that in Pakistan, once the CAR T is commenced, it will be a national news. It also gives the centers providing CAR T an opportunity to establish themselves in manufacturing facility. There's going to be an increase in the scope of CAR T. There will be new indications involving malignant hemato-oncology and also solid tumor indications, and as well as non-malignant indications. There are a number of alternative platforms which are being tried, including those which will then lead to development of commercially available allogeneic CAR Ts, CAR NKs, CAR macrophages, and so on and so forth. And last but not least, there is a significant financial incentive in public sector and private sector. Tariff in the United Kingdom set up for CAR T is significant. So it does provide financial incentive to the trusts which are providing CAR T services. This is just kind of news articles from two of our first 5 or 7 CAR T patients. And they were taken up and published in national news. One, as you can see, a positive news, and another one, not that positive. So you got to be careful, because these are high-profile treatments. This slide just shows me an example of the trials that are going on in CAR-NK, and just be aware there are more than 200 clinical trials in solid tumors. And I think once CAR-T becomes available for solid tumor, the indications will be absolutely enormous. There'll be huge demand for CAR-T and the centers providing CAR-T. So what do we need in order to build a CAR-T program? So kind of divide them into structural elements, governance elements, education and training, and obviously finances are absolutely critical. And that is really important for a CAR-T program in developing countries. So for local facility, for example, you require robust kind of investment of clinical transplant program, including clinical services, stem cell laboratory facilities, apheresis. You have to invest into personnel, in human resources. We need to build a very robust clinical structure, which will be required for accreditation, governance, regulatory authorities, inspection, audits from pharma companies, and so on and so forth. We require a comprehensive quality management program. You need to be able to deal with complications, training and education of new starters, and ongoing training and education for the staff already in post. For external bodies, you require regulatory approvals. You need to adhere to standards such as JC. You need to have a manufacturing facility that you coordinate with. It could be commercial, research, or it could be local facility for point of care manufacture. You need to have a robust coordination of delivery, receipt, and traceability is absolutely crucial. So these are different elements of CAR-T program, which many centers across the world who are undertaking auto and allogeneic stem cell program will have. So you require a collection facility, you require stem cell laboratory. I have to emphasize that the involvement of stem cell laboratory in CAR-T program is relatively minimal. So stem cell laboratory acts as a facility for receipt and delivery, or in some CAR-T products, it is required for minimal manipulation of the product that is collected after apheresis. Obviously, you require a manufacturing facility, robust legal contracts with them, where you send the product and receive back. You require a transplant program or cellular therapy program where you're able to give lymphodepletion and you're able to deal with complications. I would not go into the details, but just to be aware that CAR-T infusion is can be followed by a number of quite severe significant complications, including neurological events such as ICANS, cytokine release syndrome, and various presentations of hyperinflammation. In addition to many of the complications that can happen with auto and allogeneic stem cell transplantation. Again, it's beyond the remit of this presentation to talk about management, but just to emphasize that early recognition of complication grading of complication, and then appropriate management of a certain grade is the basic principle of CAR-T complication management. We have a number of tools available, such as iScore and other tools and algorithms which are available, which can be incorporated to clinical practice. It's very important to remember that specific drugs like tocilizumab, anakinra, siltuximab, you need to make a robust plan of when you will require it, where you're going to keep it, how to reconstitute it, who will deliver it, who makes the decision, and so on and so forth. So all of those need to be within your quality management program. This is just to show you that there are a number of guidelines available for cytokine release syndrome and ICANN management, and you have to adopt it according to your own local practices. When do you want to escalate? At what grade would you want intensive care be involved and move the patient to intensive care or high dependency unit, and so on and so forth. So this is just an example of quality management program. We have simplified our program to ensure that out of hours on-call doctors have very easy access to our quality management program. And when we have induction of our new doctors, we take them through this process. We show them exactly how to find the documents, where to find the documents. They have to go through the assessment, and then they're signed off when they're deemed competent in order to be able to look after CAR-T patients. So how do we get there? I think there's three main ways we can set a CAR-T program. Obviously, we can use commercial products within the private or public initiative. NHS England Commission Service is a public initiative here in the United Kingdom where everybody gets this treatment for free, even though it's very expensive. We can set up CAR-T programs in clinical trial with collaboration with academic programs and commercial products companies. Another way of doing it is to have your own in-house or point of care manufacturing facility for CAR-T. Again, it could be an industry and academic collaboration, or you can set up your own. So what are different challenges? I think it's very important to build a very robust bone marrow transplant and cellular therapy program. It will require expansion. You have to invest into clinical facility, into medical nursing staff, laboratory staff, apheresis unit. You have to expand their capacity when you're taking up new work. Obviously, they need retraining and so on and so forth. It will require clinical governance in order to get regulatory approvals like JC, NHS England, manufacturers will come in and audit you, HTA, Human Tissue Authority, any other local and regional regulatory bodies, MHRA if you want to be a manufacturer. So this will vary region to region, but those are some of the things that you have to do in the United Kingdom. Ongoing education and training. I think it's important to have stakeholder engagement. They will require investment from your program. You have to invest in allied medical specialties like intensive care, neurology, pharma, apheresis, stem cell lab, and so on and so forth. You need to build a robust MDT network for smooth transfer of patients for CAR-T, because sometimes obviously you need to take them through CAR-T very briskly. You don't have time, so you need to build those very powerful, strong bridges. You have to build ambulatory service. You want to discharge the patients after 14 days. You have to plan late effect. And most importantly, you need to make sure that all of this is financially viable. So you have to have robust business plan. So a recent example, when we built this program in our center in Clatterby, so we identified external and internal work streams who would meet and will be responsible and respond to CAR-T program board, who is then overseen by Transformation and Improvement Subcommittee or TIC, who is then overseen by Trust Executive Group. So within different work streams that we identified, we had leads for individual work streams, so internal and external work streams. So we meet very regularly. We will assign tasks to individual work streams. We will monitor their progress. And over a period of time, we got to a point going from initial presentation of proposal to the trust exec group on to NHS England approval and so on and so forth. So there are different ways, as I mentioned earlier, you can produce CAR-T, and I think it's very important to have an understanding of what actually CAR-T manufacture means, because the cost margin for pharma and point of care manufacture is huge. So if you look at different steps of CAR-T manufacture, you have like T-cell selection, which is not very technically challenging, like by T-cell activation, gene transfer, by transduction, electroporation, and so on and so forth, T-cell expansion. So there are different ways you can do it, either within a closed system or open system. And I think it's very important to have a standardized, decentralized, functionally closed kind of program if you do want to build your own CAR-T program to cut down the costs. One example of where we were involved in this process was a collaboration with an academic group which was collaborating with pharma industry. So it was an FMC 63 CD19 CAR. In phase 1 trial, we got involved in acute lymphoblastic leukemia. And as you can see, in the initial phase, the CAR was manufactured by a manual process using Dynabead activation, lentiviral transduction, and an open system using bioreactor. And in a later phase, Prodigy Milteni was used in order to produce the product more uniformly and at a larger scale production. And this figure kind of highlights, gives an example of CAR-T manufacture using Prodigy. As you can see, it requires about 8 to 14 days after initial processing, which is about 4 to 6 hours of hands-on time. Again, it's a closed system. It can be installed in grade C or grade D GMP facility. And as of my last assessment, the cost of point of care testing, provided you had a clinical grade lentiviral vector, was about 10 times the cost of commercially available products. Another example of manufacturing platform that we've been involved in utilizes Cocoon. And again, it's you can either couple Cocoon with the Prodigy, or you can use Cocoon all the way. Again, it has made the process of CAR-T manufacture simpler, and it can manufacture CAR-T within 7 days. So we are in the process of collaborating in order to be able to hopefully have point of care manufacturing in a local facility. And obviously, the pharma academic collaborator would want you to have certain elements of program and technical capability in place before they invest into you, invest their time, energy, effort, and finances. So you need to be able to match their technical capability. You need to have what is required. I think one of the major challenges in CAR-T manufacture is acquiring clinical grade viral vector. Obviously, you can collaborate with academic colleagues, academic groups in order to acquire that, or you can acquire them commercially, or you can go through a process of local manufacture. I have to say that that can be quite challenging. Generating clinical grade viral vector can be quite onerous. So in conclusion, CAR-T is a cutting edge, however expensive gene therapy, and there are various ways to set up CAR-T. It does require review of local resources and circumstances to evaluate feasibility and implementation of strategic plans and how you want to do it, how you want to deliver CAR-T, what are your cost model. Obviously, it's not going to be cheap, but it can be significantly cheaper than the commercially available products. It requires extensive regulatory requirement, particularly in the developed world. And I think that can be a strength in a country like Pakistan, where the regulatory requirements may not be as stringent, so you could get away. However, obviously, you want to maintain a very high standard. There will be completely different challenges in developing and developed world. I think in developing world, the biggest challenge will be finances. I think there's an absolute dire need for developing strategies to cut down the cost of treatment, not only in developing world in order to be able to give this treatment, but also in developed world. Thank you very much. Happy to take questions.
Thank you very much, Dr. Saif. So we've had 4 excellent talks, and I think I'll open the house for the Q&A session. Perhaps I'll start off with a question for Dr. Usman. So, Dr. Usman, you shared your data about CAR T cell and its outcomes in ALL in your center. My question was whether CAR T was used as a bridge to allogeneic transplant. How many of those patients actually went on to have allogeneic transplant, or that 100% curve was just the CAR T cell therapy in ALL?
Thank you very much for the question. So basically, that was, we've got now about 19. Now, those are just adolescent patients that I showed. Our pediatric colleagues have had their own pediatrics. In total, we've treated in the institution about 40 pediatric and adolescent patients with CAR T-cell therapy. And now the breakdown, I haven't got right in front of me, but that's being analyzed. But about just over half of those patients who had CAR T-cell therapy are patients who had a prior allogeneic transplant. About 60%, roughly, had a prior allogeneic transplant, and often they came from our pediatric colleagues, having had chemotherapy and a transplant, and then a subsequent relapse, etc. So our approach is, if a patient hasn't had a prior allogeneic transplant, then we would use CAR T-cell therapy as a bridge to a transplant. If they have had a prior transplant, then we would use CAR T-cell therapy as a hopefully definitive therapy. And then we very carefully monitor them after that for minimal residual disease or loss of B-cell aplasia. So we monitor the CD19 level. If the CD19, if we're starting to see the CD19 B cells are starting to appear, so you have loss of B-cell aplasia, then we would go to a second transplant. But that's roughly our approach. If no prior transplant, then CAR T-cell therapy and transplant. If they've had a prior transplant, then we would just give them CAR T-cells and monitor.
Thank you very much. Any other questions from the audience?
Assalamu alaikum. Very nice and informative session. My question is from Sarahil. As extracorporeal photopheresis is only available in your institution, can you please share your experience regarding it? How many patients have undergone this therapy, and what about the sessions required? What about the cost? And second question is from Sarahil as well as from Dr. Munira. That is for MRD positive ALL. In your institutions, after how many cycles patients receive MRD negative status? Because we have seen in our institution that most of our patients, they do require more than one BLINA cycle to achieve MRD negative status. So what's your experience regarding it? Thank you.
Thank you very much. So at our center, we actually have got an off-circuit ECP machine. We know that it is on circuit and off circuit. So it is off circuit machine. We have used it in 3 patients, and all of them, 2 of them had indication that they had severe basically joint and facial involvement, myofascial involvement, and both of them responded actually. One of them was a girl. She was around 17 years of age. She had disabling rheumatological involvement, and actually it improved significantly. Other was a child around 6 years of age. He also had started developing contractures, failed RUX, and then he was given ECP. Third was another girl who had hepatic and gut involvement. She didn't respond. The cost of each session is around 1.5 lakhs. And actually we have to do initially twice weekly, then weekly, and then fortnightly. So around 12 to 14 sessions are required, and it would be costing around 3 million. And your second question regarding the number of cycles that are required for Blina, I'm not sure. I don't have data in front of me. I'm not sure about that, but there are a few patients who required 1 cycle, few had couple of cycles. And I remember 2 patients who actually were MRD negative after first cycle. There was delay in transplant. We gave them another cycle and they relapsed actually post Blina. So thank you.
So with regards to your second question, I think a little bit more elaboration on what kind of ALL are we really looking at, right? So if you're talking about Philadelphia negative B cell ALL, so isme Blina can be, the study looked at MRD negativity after 2 cycles, but we tend to just check after every cycle so that patient ke paise bach jaye. But it is really about so I think your question was predominantly specific to Blina, but I think this kind of applies to the entire landscape of ALL. You kind of like have to differentiate ke bhai T cell, maybe what kind of T cell are you looking at, and so on. So
just a question and a comment for Saif. I'm honored to have him as a junior in medical school, and he's gone a long way in cellular therapies. And so when we talk about CAR-T, it's all revolves around finances and money. It's more complex than this. There's a lot of, even in Pakistan, actually it may be worse, the regulatory workup. The Drug Regulatory Authority of Pakistan, DRAP, now oversees all these cellular therapies whenever we bring them. And you remember that trial from Australia where they tried CRISPR as a mean of gene modification, and 2 out of 10 patients developed lymphoma. With the recent Great Ormond study for T cell CAR-T, 1 of 3 patients died of fungal infection. So we talked to our Chinese colleagues. We collaborated with about 40 hospitals in China. None of them was willing to start a CAR-T trial in Pakistan. We've sent about 10 patients to China for CAR-T, all of whom relapsed after CAR-T, except 1 who just underwent an allogenic stem cell transplant. And Chinese government has strict regulations. They will not allow transfer of living cells in or out of China without government approval. So you cannot just directly collaborate with the hospital. You have to go through the Chinese government. So the regulatory workup is also getting more complex as we move forward.
Dr. Saif, your comments?
Can you hear me?
Yes.
I apologize. I'm in rural part of Pakistan. I thought it would be easier to speak to you whilst I'm in Pakistan, but it seems like it's the other way around. We had some kind of internet breakdown here. So I've got 3 devices switched on to try and keep me connected. Thank you, Dr. Riaz. Yeah, I can see how the CAR-T field, as it evolves in future, that you may have very complex mechanism of regulatory approvals and so on and so forth. But I also feel that right now you are in kind of, early phases of developing these programs. So maybe your, the community on your side, physicians and all those who are connected, they should try and steer it, because I think you should try and make it simpler. Now, my advice would be that go for a low-hanging fruit to start with. For example, if you send a ALL patient who is quite advanced to either abroad or somewhere where you know that it's unlikely to work because of the delays, for example, and because of efficacy. For example, if you, I'm sure you've looked at the CARTIS data, long-term follow-up shows that many patients do tend to kind of relapse as well, and so on and so forth. So I think if you target low-hanging fruit in illnesses where it's more effective, and with the CAR-T CD19 4-1BB products, for example, which are relatively well studied and you got some efficacy data, and they're relatively easy to manufacture. So start, rather than being like picky, you can just start with something that's very well established. Now, bringing something here in Pakistan will certainly be a problem, and I completely connect to you and understand when you say that there were, we have also seen a higher incidence of fungal infection in some products and so on and so forth, and that I can only imagine will be significantly worse in Pakistan, where the environment is such that even after allo transplants, in cases of patients where I was involved in, there was a very high incidence. So I think you'll have to modify your practices and give reassurance to your foreign colleagues that you're providing a very high quality service, as good as any other part of the world, and develop those very possibly kind of personal connections with them in order for those companies to come and work with you. And that's all I can suggest, really, because many a time these research collaborations can have multiple elements attached to them. They can be, I was in a part of the world where it became rather political to start CAR-T, and then we had to resort to a slightly different model. So I think you'll have to be very agile, and you will have to be very, very smart when you're engaging with your colleagues, and reassure them, develop those very powerful, strong connections, and hopefully it will happen. It is doable.
Thank you. I have one question for Dr. Rahil. Dr. Rahil, you mentioned about ATG becoming a standard in preventing chronic GVHD, even in malignant cases. So I think the only issue with that is there's no doubt that it reduces your risk of chronic GVHD and acute as well. It's the worry about increased risk of relapse and also the infections. So now that we have some studies coming out showing the efficacy of post-transplant cyclophosphamide, even in related settings, in RIC, obviously, it's been shown to be very good without compromising your relapse risk. So what are your comments about, going with post-transplant cyclophosphamide instead of the ATG, cheaper, and also not compromising your relapse risk? And second thing about ALL with the benefit of TBI, again, the toxicity is an issue. And there's some data about reducing the TBI from 12 gray to 8 gray. So any sort of comments about modifying the conditioning in that regard?
Thank you very much. Excellent questions, very pertinent. So first of all, relapse risk with ATG. So there were initial concerns of relapse, but we know the data that was published later, especially the article by Professor Mohti that was published in BMT, and a meta-analysis actually proves that there was no significantly increased relapse, especially the doses of ATG which were modified later. It started, we know, from 60 to 80 milligram per kg, and then it reduced to 5 to 10 milligram per kg. So if you're given 5 to 10 milligram per kg of ATG, the cost is significantly reduced. The risk of relapse, it does not increase, and chronic GVHD is reduced significantly. And we have a lot of data from PTCY, but somehow what we have seen in our limited experience, I'll say, of haploidentical transplant, PTCY in our setting has got its peculiar problems. There is a lot of CMV reactivation. There is even cardiac decompensation, which we have seen in our patients. And hemorrhagic cystitis, our patients actually struggle with that. So I think there would be head-to-head comparison. Definitely it will be coming, but I think it can be individualized. And if we are using a low dose of ATG, especially in high-risk patient, multiparous donor, PBSC, in a malignant disorder, I think it is a very convenient way to address chronic graft versus host disease. And regarding your second question of TBI, so once there were toxicity concerns, there were concerns with IQ abnormality, there were shifting of conditioning regimen from TBI, and one of them in which there was a lot of interest which was shown was TBF, thiotype bu flu regimen, and it was said that it will be one of the regimen that will be equivalent to TBI and replace that. But unfortunately, TBF has not proven to be an alternate of TBI, and this was a systematic review. There was last year a randomized trial which again shows that if you reduce TBI to 8 Cray, the toxicity concerns are mitigated, but the efficacy and the relapse risk remains the same. So as per my knowledge, TBI remains the standard of care for ALL.
Thank you very much. Dr. Osman, did you have any comments, your practice in Saudi, about ATG, T cell depletion, post-transplant cyclophosphamide?
Okay, so we do something slightly peculiar, which we've been doing haplotransplants for about since about 2013, 2014. And initially, actually, what we found, we used the Italian platform of bacigalup, so it's a thiotype sulfan fludarabine with the PTCY. And we found more GVHD than we had expected and then was published. So we actually had to add in a bit of ATG. So they get about 2.5 milligrams per kilogram of ATG as well, split over 2 days. So that did actually reduce. So it's strictly no longer a T cell replete haplo platform. We have some T cell depletion, and that had reduced the incidence of severe GVHD from what we had seen in our initial cohort. But as Dr. Raheel mentioned, we do see a lot of hemorrhagic cystitis. We see the CMV reactivation as expected. Most cases we're able to control that. We don't see much in terms of severe CMV disease, but what we do see a lot of severe hemorrhagic cystitis. And the other thing is what we found, and we found it to be statistically significant, is the tolerance of our older patients for the haplo platform. So patients over 60 don't do very well with the haplo. So that's for the haplo ATG story. We haven't moved to PTCY as a standard GVHD prophylaxis. We're still using calcineurin MMF, although we have a randomized study ongoing for acute leukemia in the myeloablative setting, where patients are being randomized to a myeloablative conditioning, flu-bu, and then randomized to either calcineurin inhibitor MMF versus PTCY. That's without ATG, and we're waiting for that to be analyzed. But so for standard myeloablative transplants, our standard is still a calcineurin inhibitor MMF. We don't use ATG as a standard unless it is in a single antigen mismatch or in the MUD setting. And we have a fair number of MUDs from the Saudi registry. And we do the PTCY with a bit of ATG in those who don't have a matched sibling donor.
Thank you very much, Dr. Osman.
Thanks.
We use ATG for benign disease. We use post-Cy even in matched sibling transplants because there's data to show mitigate CVHD without affecting your risk of relapse. And we're using 80 milligram per kilogram of post-Cy instead of 100. 40 plus 40. 40 plus 40. We'll see what the outcomes are.
Any other questions?
Can I make a quick comment?
Yep, sure.
So we quite extensively use post-Cy in our patients, not only in the context of haploidentical transplant, but also for sibling and unrelated donor. And just like our colleagues in KSA, we actually had to incorporate within our protocol Two things. First of all, we did see a high incidence of CMV, but then letermovir became available, which has really cut down the incidence of CMV reactivation. So that issue is no longer an issue for us. Secondly, in order to control GVHD a little bit better, we have added in addition to MMF and calcineurin inhibitor platform, we've also added in a beta set, which is CTLA4. So in this combination, we're seeing excellent outcomes. We're in the process of submitting data on our haploidentical transplant, where we're seeing with about 25 months median follow-up, we're seeing over 70% survival in haploidentical setting, which is actually better than some of the siblings and unrelated donor data that has been published, and we're seeing excellent outcomes in sibling and WUDs as well. So I think that there are lots to do. Recent Chinese data shows that you can reduce the you can add in additional like ATG in a lower dose. So I think in future post-transplant cyclophosphamide would most likely, almost certainly be coupled with either some form of T depletion strategy or CTLA4 or some other form of GVHD prevention elements prophylaxis into the conditioning regimens. So a lot that will happen, I think, in this area.
Thank you very much. If there are no further questions, then I think we can close the session. Those were excellent talks by the speakers, and I thank them again. Thank you all.
Thank you.